Welcome to the deep dive. Today, we're tackling something you might think is pretty basic, but trust me, for all you medical microbiologists out there, there's a lot more to pharyngitis than meets the eye.
Yeah, it's one of those things so common, almost everyone's dealt with it, but when you look at it through the lens of antibiotic overuse, globally, it becomes a much bigger issue.
And that's exactly why we're diving into Chapter 6 of the WHO's AWARE guidelines. Access, watch, reserve. Their roadmap for tackling antimicrobial resistance, and for us today, specifically how it relates to pharyngitis.
Right, because it's not just about knowing how to treat a sore throat. It's about using that knowledge responsibly, making sure we're good stewards of these antibiotics.
Exactly. So before we get into the details, let's start with the basics. What exactly is pharyngitis?
Well, simply put, it's inflammation of the pharynx, the back of the throat. But for a microbiologist, the real question is, what's causing that inflammation?
Right, because as we know, the clinical presentation can be pretty tricky. A patient comes in, sore throat, maybe a headache, a cough, some muscle aches. Could be viral, could be bacterial. How do we tell the difference?
That's the challenge. We have to look for those subtle clues that might point us in the right direction.
So what are some of those clues? What really makes us suspect a bacterial infection?
Well, one of the first things we look for is fever, and not just a low-grade fever. We're talking 38 degrees Celsius or higher.
Okay, so fever's a red flag. What else?
Tender cervical lymph nodes are another big one. If those nodes are swollen and painful, that's a sign of inflammation, possibly driven by bacteria.
So we're looking at fever, swollen lymph nodes, anything else that screams bacteria.
Absolutely. The presence of pharyngeal exudates, those white patches or streaks on the tonsils or the back of the throat.
The exudates, classic sign. But we're not just eyeballing it, are we? There's a system to help us quantify these findings, right?
Exactly. That's where the Centor Clinical Scoring System comes in. It gives us points for each of those features: fever, absence of cough, tender lymph nodes, and exudates. The higher the score, the more likely it is we're dealing with a bacterial infection, specifically group A strep.
Right. Group A strep, Streptococcus pyogenes, and the concern about complications like rheumatic fever. Okay, so we've got our clinical observations, we've got a scoring system, but as microbiologists, we want more than just suspicion. We want evidence.
Absolutely. And that's where the lab comes in. The WHO EDL recommendations in the AWARE guidelines give us a framework for choosing the right tests.
Okay, so lab tests. What are we looking at specifically? When it comes to microbiology, what are the best ways to figure out if it's bacteria causing the pharyngitis?
The WHO guidelines really focus on two main tests: rapid antigen detection tests, or RADTs, and then the good old-fashioned throat cultures. Each has its own strengths and weaknesses, and which one you use often depends on the situation, what's going on with the patient and what resources you have available.
Let's break those down a little more, starting with the RADTs. What makes them so useful, and what are some of their drawbacks?
Well, the biggest thing RADTs have going for them is speed. You can get results in minutes, which is huge when you're trying to make quick decisions about treatment, especially if you're thinking about antibiotics.
Yeah, that speed can really make a difference, especially in a busy clinic. But how accurate are they? Can we really trust them to guide our decisions?
That's where things get a little trickier. They're pretty good at picking up group A strep, but their sensitivity isn't perfect.
So if a RADT comes back negative, doesn't necessarily mean we're in the clear, right?
Right. If you still have a strong suspicion of strep, even with a negative RADT, you really need to consider a throat culture to be absolutely sure.
Which brings us to throat cultures. The gold standard, but they do take a bit longer. What are the advantages there?
Throat cultures are more sensitive than RADTs, so you're less likely to miss a case of strep. The downside is you have to wait for the results, usually 24 to 48 hours.
Right, that waiting game can be tough.
Yeah.
So how do we decide which test to use? Does the WHO give us any guidance on that?
They do. The AWARE guidelines recommend a tiered approach based on, how well equipped your lab is. If you have a good lab with everything you need, you can use both RADTs and cultures. But in places with limited resources where maybe cultures aren't readily available, you have to rely more on your clinical judgment and be more selective when you use RADTs.
Makes sense, adapting to the situation you're in. Now, before we move on to treatment, what about other lab tests? Like, do we typically order blood work for pharyngitis?
Usually no. Unless there are complications or we need to rule out something else, blood tests aren't really necessary for a straightforward case of pharyngitis.
So no need for a CBC or inflammatory markers for the average sore throat?
Nope. And another interesting thing the guidelines point out is that you don't need routine surveillance testing to pick which antibiotic to use for strep pharyngitis.
Huh. Why is that?
Because, thankfully, Streptococcus pyogenes is still susceptible to our first-line antibiotics, like penicillin, so we don't have to worry too much about resistance patterns when we're choosing our initial treatment.
Okay, that's good to know. Last question on diagnostics. What about imaging? Any role for x-rays or anything like that in evaluating pharyngitis?
Just like blood tests, imaging is really only needed if we think there might be complications, like an abscess, or if the presentation is unusual for some reason.
So not part of the routine workup for a simple sore throat. All right, let's shift gears now and talk about treatment. I think it's worth emphasizing right off the bat that most cases of pharyngitis are viral, not bacterial.
Definitely. I think that's a point that often gets missed. Most sore throats will go away on their own, just with a little time, and some help managing the symptoms.
Which means antibiotics aren't always the answer. So for those viral cases, how do we help patients feel better? What does the WHO recommend?
The guidelines recommend sticking with simple things like paracetamol or ibuprofen to take care of the pain and fever.
Good old-fashioned pain relievers. Can't go wrong with that. Dosages can be tricky, though, especially for kids. Does the WHO have any specific recommendations there?
Yeah, they do. If you look at Table 6.4 in the guidelines, they have weight-based dosage charts for both paracetamol and ibuprofen. For example, for a child between, say, 10 and 15 kilograms, they recommend 120 milligrams of paracetamol every 4 to 6 hours or 100 milligrams of ibuprofen every 6 to 8 hours as needed.
That's handy to have. All right, let's tackle the big question now. When are antibiotics actually necessary for pharyngitis?
This is where things get a little more complicated, and the global picture really matters. The WHO guidelines actually make different recommendations depending on how common rheumatic fever is in a particular region.
Ah, yes, rheumatic fever, the complication we're trying to prevent with antibiotics, right? That can cause permanent damage to the heart.
Exactly. And it's way more common in some parts of the world, like Africa, Southeast Asia, and the Western Pacific than others. So the WHO has tailored its recommendations to account for those differences.
Okay, let's break it down by region then. Starting with areas where rheumatic fever isn't as common, how do the guidelines approach antibiotics?
In those low prevalence areas, antibiotics are rarely needed, even if the Centor score suggests it might be strep. The thinking is that the risks of using antibiotics, side effects, messing with the gut microbiota, all that, outweigh the benefits, which are really just a slightly shorter illness.
So in those cases, we're essentially saying, let the body do its thing.
Pretty much. Better to be safe and reserve antibiotics for when they're really needed.
Makes sense. What about places where rheumatic fever is more common? How does the approach change?
That's where we have to be more proactive. In those medium to high prevalence areas, antibiotics are usually indicated if we have a strong suspicion of strep pharyngitis, especially in younger patients, because they're the ones most likely to have a recurrence of rheumatic fever.
So it's about balancing the immediate benefit of treating the infection with the potential long-term risks of not treating it adequately. Okay, so we've talked about when to use antibiotics. What about the specific antibiotics? What does the WHO recommend?
When antibiotics are needed, penicillin is the go-to first-line treatment. Amoxicillin and phenoxymethylpenicillin are the preferred options. They both fall under the access category in the AWARE classification, which means they're really important for responsible antibiotic use.
And I'm sure there are specific dosage instructions, right? We need to make sure we're giving the right amount for the right lengths of time.
For sure. The guidelines have a detailed table, Table 6.5, with all the dosages, taking into account age and weight. So, for example, for adults, amoxicillin is usually 500 milligrams every 8 hours, and phenoxymethylpenicillin is 500 milligrams every 6 hours. You generally give them for 10 days to make sure you wipe out all the bacteria.
Okay, penicillin's our first choice. What if someone's allergic to penicillin? What are the alternatives?
The guidelines recommend cephalexin, or clarithromycin, as second-line options. Cephalexin is a cephalosporin, and clarithromycin is a macrolide. Table 6.5 has the dosages for those too, both for adults and kids. Usually, it's 500 milligrams of cephalexin every 12 hours, and the same for clarithromycin.
Perfect. Anything else we should keep in mind when choosing between these antibiotics?
Oh, yeah. One important thing to remember is that macrolide resistance can be a problem, especially with clarithromycin, so you always have to check your local resistance patterns before you prescribe it.
Great point. We can't forget about those local factors.
Yeah.
All right, so we've covered when to use antibiotics and which ones to use. But before we move on, let's talk for a minute about how this all works. Well, how do these viruses and bacteria actually cause the inflammation and pain we see in pharyngitis?
Ah, the pathophysiology, fascinating stuff. Both viruses and bacteria target those mucosal cells lining the pharynx. They get in there and start replicating. And that invasion triggers an inflammatory response, which is what causes all those classic symptoms. The sore throat, the redness, the swelling.
A battle at the cellular level. Tiny invaders messing with our throats. Okay, let's zoom out a bit now and look at the big picture. Epidemiology. What are some of the key takeaways about pharyngitis globally?
Well, one of the most striking things is that even though most cases are viral, studies have shown that up to 60% of people with sore throats in high-income countries are getting antibiotics.
Wow, that's a lot. Really drives home the point about overprescribing and the need for more judicious use of antibiotics. What about the complications like rheumatic fever? How does that play out globally?
The burden of rheumatic heart disease, which often starts with untreated group A strep pharyngitis, is significant. It affects something like 30 million people worldwide and causes over 300,000 deaths every year. But it's not evenly distributed.
You mean some areas are hit harder than others?
Exactly. As we mentioned earlier, rheumatic fever is mostly concentrated in specific WHO regions like Africa, Southeast Asia, and the Western Pacific. India, in particular, carries a huge burden. They have about a quarter of all the cases globally.
That really highlights the health disparities that exist around the world. Okay, last question on epidemiology. What are the usual culprits behind pharyngitis? Who are the main offenders?
As we've been saying all along, viruses are the most common cause. Things like rhinoviruses, coronaviruses, influenza viruses, they're the top of the list. You also see cases caused by Epstein-Barr virus, the one that causes mono, and less commonly, SARS-CoV-2.
Right, we can't forget about COVID-19 as a possible cause of sore throat. And what about bacteria?
Streptococcus pyogenes, our group A strep, is still the main one we worry about, although group C and G can also cause pharyngitis.
Anything else we should be aware of besides those common ones?
Yeah, it's important to remember that there are other less common infectious causes out there. Things like acute HIV infection, sexually transmitted infections like syphilis and gonorrhea, acute toxoplasmosis, even diphtheria, although that's pretty rare now in many places thanks to vaccination.
Diphtheria. A good reminder that vaccines can make a real difference. Anything else?
Oh, and it's worth remembering that not all sore throats are from infections. Non-infectious things like air pollution, allergens, smoking can also irritate the pharynx and cause those same symptoms.
Right, good point. So much to think about. Okay, are you ready for a little challenge? Let's see how much you've learned with some exam-style questions. Think you can handle it?
Bring it on. Let's see if I remember everything.
Okay, first question. A 30-year-old patient comes in with a sore throat, fever, and tender cervical lymph nodes, but no cough or exudates. Their Centor score is 2. We're in a region with a low prevalence of rheumatic fever. What's the best way to manage this case? A, amoxicillin for 5 days, B, phenoxymethylpenicillin for 10 days, C, symptomatic treatment and observation, or D, throat culture, and then antibiotics if it's positive for group A strep.
This is a good one. Really makes you think about the whole picture. The right answer is C, symptomatic treatment and observation.
So we're just watching and waiting for now? Why not the other options?
Well, A and B, jumping right to antibiotics, that's too aggressive. The patient's not that sick, and in this area, the risk of rheumatic fever is low, so it's not worth the potential downsides of the antibiotics. And a throat culture, option D, might be useful sometimes, but here with a Centor score of 2, it's probably not necessary. We'd save that for cases where we're more concerned about strep, or if rheumatic fever was a bigger issue.
Yeah.
Makes sense. Ready for number 2?
Hit me.
Okay, here we go. We've got a 5-year-old child living in a region with a high prevalence of rheumatic fever. They have a fever, sore throat, exudates, and tender lymph nodes. Centor score is 4. No allergies. What's the recommended first-line antibiotic and how long do we give it for? A, amoxicillin, 80 to 90 milligrams per kilogram per day for 5 days. B, phenoxymethylpenicillin, 10 to 15 milligrams per kilogram per dose every 6 to 8 hours for 5 days. C, clarithromycin, 7.5 milligrams per kilogram per dose every 12 hours for 10 days. Or D, amoxicillin, 80 to 90 milligrams per kilogram per day for 10 days. Okay, this one gets right to the heart of those regional differences in treatment. The answer is D, amoxicillin, 80 to 90 milligrams per kilogram per day for 10 days.
Let's walk through that. Why is option D the best choice?
All right, so in these high-risk areas, we have to be more careful with potential strep pharyngitis, especially in little kids, because they're the ones most likely to get rheumatic fever again if it's not treated properly. With a Centor score of 4, it's almost definitely strep. So we go with amoxicillin, that's our first-line choice, and we give it for a full 10 days to make sure we really get rid of those bacteria and prevent rheumatic fever from coming back.
So the longer duration is key here. What about the other options?
Option A has the right drug, but the wrong length of treatment. 5 days isn't enough in this situation. Option B, phenoxymethylpenicillin, that's a good first-line choice too, but again, it's not given for long enough. And option C, clarithromycin, that's a second-line drug, so we wouldn't use it first unless the patient was allergic to penicillin.
2 down, 3 to go. Question number 3. A lab report comes back and says the cause of pharyngitis is group C, Streptococcus. This is an adult patient. Which antibiotic would you choose? A, amoxicillin, B, cephalexin, C, clarithromycin, or D, any of the above?
This one tests your knowledge of different strep species. The answer is D, any of the above. We usually focus on group A strep, but group C and G can cause pharyngitis too. And the good news is they usually respond to the same antibiotics we use for group A.
So we have some flexibility in our treatment choices. Why is that?
Well, these Streptococcus species, they have similar susceptibility patterns, which means they tend to be susceptible to penicillin, cephalosporins like cephalexin, and macrolides like clarithromycin. Which one you pick might depend on local resistance patterns or whether the patient has any allergies.
Makes sense. On to question 4. Which of these statements about rapid antigen detection tests, or REDTs, for pharyngitis is true? A, they're highly sensitive and specific for all bacterial causes of pharyngitis. B, they're recommended for all patients with a sore throat, no matter what their Centor score is. C, a negative REDT means it's definitely not group A strep pharyngitis. Or D, they give you quick results, which helps you decide about antibiotics sooner.
This one's all about those diagnostic tools. The correct answer is D. They give you quick results, which helps you decide about antibiotics sooner. That's their biggest advantage, fast information.
Okay, what about the other statements? Why are they wrong?
Well, statement A is too broad. REDTs are really designed for group A strep, not for every type of bacteria that can cause pharyngitis, and how well they work can vary too. Statement B is wrong because, like we talked about earlier, we don't test every single person who has a sore throat. We use the Centor score to be more selective. And statement C, that one's a little tricky. REDTs can be helpful, but a negative result doesn't completely rule out strep. If we're still suspicious, we might need to do a throat culture to be sure.
Last question. Which of these complications of untreated group A strep pharyngitis is a major public health concern, especially in certain parts of the world? A, otitis media, B, sinusitis, C, bronchitis, or D, rheumatic fever?
This one should be easy for our listeners. The answer is D, rheumatic fever. That's the complication that makes group A strep pharyngitis so dangerous, especially in places where it's common.
Right, and why is that?
If you don't treat group A strep pharyngitis, it can trigger an autoimmune reaction that leads to rheumatic fever. And rheumatic fever can damage the heart valves, which can then cause rheumatic heart disease. That's a chronic condition that can really affect people's lives and even be fatal.
So it's not just about getting rid of the sore throat, it's about preventing these long-term problems. Why are the other options wrong?
Well, otitis media, sinusitis, bronchitis, those can be complications of other respiratory infections, but they're not directly caused by untreated strep throat. Rheumatic fever is the one we really have to watch out for with strep.
You aced the quiz.
That was a good review. Really helped solidify those WHO guidelines.
I agree. Who knew there was so much to a simple sore throat? We started off saying really a whole episode on this.
Yeah.
But I think we've learned a lot, uncovered a lot of nuances and important things to consider.
It really shows why it's so important to stay up to date on the latest guidelines, especially when it comes to something as globally important as antibiotic stewardship.
Absolutely. The WHO's AWARE guidelines are a fantastic resource for making sure we're managing pharyngitis responsibly and effectively.
For sure. It's all about being thoughtful, not just prescribing antibiotics because someone has a sore throat. We have to use these powerful drugs wisely to make sure they keep working for the people who really need them.
And those disparities in rheumatic fever around the world, they're a reminder that access to good health care and responsible antibiotic use go hand in hand.
Yeah, that's something important to think about. We can't just focus on our own practice. We have to think globally. How can we help improve diagnostics, surveillance, and education in those high-risk areas?
A lot for our listeners to consider.
Yeah.
So that wraps up our deep dive into pharyngitis. We hope you learned something and maybe even got a new perspective on this common problem. We encourage you to check out the full AWARE guidelines on the WHO website if you want to learn even more.
It's a great resource.
Until next time, keep learning, keep asking questions, and remember, even a simple sore throat can be surprisingly complex.